everybody. Welcome to the Bertec Knowledge Series. As you heard, if you're just coming in here, this is being recorded. We always post these on our Bertec YouTube channel at Bertec HQ, just a few business days after the fact. You can find it there if you've missed anything. And of course, you can subscribe. We would love that. We are very excited today to have a webinar called Tests of VOR Compensation, Dynamic Visual Acuity, or the DVA test, and its clinical application with Dr. Kamran Barin. And so I will introduce them in just a moment, but just a couple of administrative reminders about the format of the webinar. We keep everyone's videos off and their audio off, so you don't have to worry about popping in here unannounced. But if you do have any questions at all, please go ahead and put them in the chat. I'm going to be playing Dr. Barin's pre-recorded presentation. And during that time, if any questions pop up, they can go ahead, Charlie and Cameron can go ahead and answer those in the chat. And then we'll reserve time at the end for additional questions as well. So with that, I wanted to just introduce our presenter. Dr. Kamran Barin, PhD, is Assistant Professor Emeritus, Department of Otolaryngology, Head and Neck Surgery, and Department of Speech and Hearing Science, The Ohio State University. He established and served as Director of the Balance Disorders Clinic at The Ohio State University Medical Center for over 25 years until his retirement in June of 2011. He's published over 80 articles and book chapters and has taught national and international courses and seminars in different areas of vestibular assessment and rehab. He's a consultant to Interacoustics Denmark and Bertec Corporation in Columbus, Ohio. We're very lucky to have him weighing in on product development and all kinds of things at Bertec. And then as my co-host here today, for a little change up, instead of Fernando Santos that you might be used to, we have Dr. Charlie Shearer, who's hosted a few webinars of his own. And he is in private practice in Indiana. He's been a nationally recognized leader in areas of vision therapy, visually related learning problems, and sports vision enhancement. He's worked with U.S. Olympic athletes and teams, professional and amateur athletes, and coordinated national screening of both Special Olympics and Junior Olympics. He's a leader in the field of instrumentation development as related to his role of vision science consultant for Bertec Corporation, as well as his work with other companies. So welcome to both of you. Thank you for being here. And here we go.
Today I would like to talk about the Dynamic Visual Acuity Test, or DVA, and its clinical applications. In particular, I will discuss how the DVA test can evaluate the VOR compensation. The role of the vestibulo-ocular reflex, or VOR, is to provide clear vision and to maintain visual acuity during head movements. Abnormalities in the VOR pathways cause loss of visual acuity during head movements and can lead to symptoms such as oscillopsia. Visual acuity during head movements improves with compensation even when the VOR damage is permanent. The Dynamic Visual Acuity Test, or DVA, can document loss of visual acuity during head movements and can provide an indirect measure of compensation over time. In this presentation, I will discuss the pathophysiology of vestibular compensation and provide an overview of how the DVA test changes with compensation. The vestibular system behaves essentially as a three-dimensional scale. The changes in the balance between two sides tell us about the direction and amplitude of head movements. For simplicity, only the head movements in the horizontal plane or the plane of the lateral semicircular canals will be considered here. When the head is at rest, the tonic neural activity from the right or left sides are equal. This is depicted as the sides of the scales being in equilibrium. When the head moves to one direction, neural activities from that side increase, and at the same time, neural activities from the opposite side decrease. The faster the head moves, the bigger the difference in neural firings from the two sides. So as I mentioned, the brain knows that the head is moving in the direction of higher neural firing, and it also learns how fast by looking at the degree of neural asymmetry between the right and left sides. The information about head movements is sent to the eye muscles through the vestibular and oculomotor nuclei. This information is used by the VOR to move the eyes with the same velocity as the head, but in the opposite direction. Let's assume that this patient is moving his or her head sinusoidally side to side, as shown here in the top tracing. For a person who has a normal VOR function, eye velocities will be essentially equal, but in the opposite direction of head movements. The parameter, retinal slip, is defined as the difference between the head and eye movements. So in this graph, the eye velocity represents the movement of the eyes with respect to the head, whereas the retinal slip represents the absolute movement of the eyes in space. When retinal slip is zero or very small, it means that the image of objects are staying stationary on the retina, which is necessary to have clear vision during head movements. So the function of the VOR is to minimize the retinal slip during head movements. When there is damage to one of the vestibular systems or its neural pathways, immediately after that unilateral loss, the neural firings from the damaged side decrease and the patient perceives the head moving toward the intact side. But because this motion is not real, a sensory conflict arises mainly between the visual and vestibular cues, and the patient experiences vertigo and other associated autonomic symptoms like nausea. The asymmetry in the right-left VOR pathways is manifested as spontaneous nystagmus, which is defined as nystagmus that's present in the absence of visual and vestibular stimulation. The slow phase of the nystagmus moves the eyes in the opposite direction of the perceived head motion, and when the eyes reach their orbital limit, the fast phases of nystagmus snap the eyes back to the center. That means the fast phases beat away from the site of lesion. Basically, the slow phase of the nystagmus is mediated by the VOR, which operates at the brainstem level without any involvement from higher level brain centers. The fast phases of nystagmus originate from the saccadic system, which requires involvement of higher cortical centers. The intensity of the spontaneous nystagmus is indicative of how fast the patients perceive their head is moving and how symptomatic they are. DVA testing is not particularly helpful for patients in this stage of lesion, but it can help with establishing a baseline for future testing. Over the course of several days, through the process of vestibular compensation, the tonic neural firing is restored to the damaged side, and the patient's symptoms and spontaneous nystagmus disappear as long as the head remains still. This is a milestone in the recovery of the patient, and it represents static compensation. The intensity of spontaneous nystagmus directly corresponds to the level of static compensation. In animals, static compensation depends on mobility and visual stimulation. In other words, if we immobilize and blindfold the animal, static compensation may be delayed or not achieved fully even if after you allow movement and visual stimulation. In humans, static compensation is usually spontaneous, but vestibular exercises can expedite the recovery. In patients with the unilateral loss of vestibular function, when the head moves as before, neural firings change only half as much, and as a result, the head movements are underestimated. That means the eye velocity is also half as large as the head velocity. Because the eye movements are not fully compensatory, the eyes do not remain stationary in space during head movements. Here you see that the mismatch between the head and eye velocities causes retinal slip. As a result, the images do not stay stationary on the retina and vision becomes blurry during head movements. In other words, dynamic visual acuity deteriorates because of the retinal slip. The amplitude of retinal slip can be reduced if the brain learns the new pattern of neural firing and moves the eyes faster in response to head movements. This is the next milestone in the recovery, and it represents dynamic compensation. Dynamic compensation seems to be a much more complex process compared to the static compensation, and it's not known if it can fully restore visual acuity. I casually mentioned that when we move our heads, the brain associates the corresponding neural firing patterns with the specific pattern of head movements. But how? That's not something that we are born with. One hypothesis is that the existence of a lookup table or database that for every pattern of head movement, we have a corresponding neural firing pattern. This database is probably formed early in life, which may explain why children can engage in the type of movements that may not be easily tolerated in older ages. In fact, part of the play activities in childhood may be related to the formation of this database. The support for this hypothesis comes from the fact that the morphological development of the labyrinthine structures seems to be complete within a few weeks after birth, but the central vestibular pathways continue to mature for 10 to 15 years afterwards. After a vestibular loss, this database becomes essentially useless, and the process of dynamic compensation is to replace that database with a new one. Remember that the original database was formed at an age when all of the sensory and motor functions are at their peak. We are trying to replace the database when people are not as active as before, they have cataracts, and their muscles are not as strong. It's a much more difficult task now. The rehab specialists use head-eye coordination exercises such as X1, X2 exercises, which are intended to promote dynamic compensation through adaptation and central programming of vestibular pathways. In other words, these exercises are aimed at helping the patient to replace their damaged database with a new one that can better predict the neural patterns. Let's discuss X1, X2 exercises in more detail. For those of you who may not be familiar with them, they're basically gaze stabilization exercises that can improve head-eye coordination. The therapist usually sends the patient home with the description of what he or she is supposed to do. The patient is instructed to focus on a target, such as a business card with writings on it, and hold this card at arm's length. The patient is supposed to start moving the head side to side slowly and then increase the velocity to the point where the writing starts to become blurry. The patient is also instructed to stay around the same velocity for several seconds and then to repeat the exercises a few more times. The aim is to gradually increase the head velocity where things become blurry so that the patient's dynamic visual acuity can improve for higher head velocities. In the X1 part of the exercise, the target or the business card is stationary and can be held in hand or affixed to the wall. In the X2 exercises, the patient usually holds the card at arm's length and moves it either in the same direction with the head or in the opposite direction of it. The head movements are usually prescribed for both horizontal and vertical planes, and in rare occasions, movements in the roll plane are also included. Knowing at what head velocity the patient should start the exercises can help with more optimal course of recovery. I will talk about the gaze stabilization test that can help the therapist with knowing the starting head velocity for exercises. Back to physiology. For higher head velocities, the mismatch between the head and eye velocities is worse when the head moves toward the side of lesion. The reason is that when neural firings reach zero, they cannot decrease no matter how much the head velocity increases. That means dynamic visual acuity is more severely affected when the head moves toward the side of lesion. This slide shows the difference in the retinal slip for head movements toward and away from the side of lesion. For half of the sinusoid, where the head is moving toward the side of lesion, the retinal slip is larger compared to the other half. As a result, dynamic visual acuity is worse for head movements toward the side of lesion. In patients who suffer from severe bilateral vestibular lesions, the VOR function is mostly impaired. In these patients, head movements cause large retinal slips and result in severe deterioration of visual acuity bilaterally. Interestingly, therapists often use the same X1, X2 head-eye coordination exercises, but instead of adaptation of vestibular pathways, the aim is to promote substitution of vestibular sensors with oculomotor and neck receptors. This brings us to the dynamic visual acuity or DVA test. Traditional vestibular tests, such as the caloric test, video head impulse testing, or vestibular evoked myogenic potentials, these tests are intended to identify presence of pathology. That's useful because the test results remain essentially the same as long as the pathology is stable, but they do not give any indication of the level of compensation. DVA is one of the few tests where the test results can change with the level of dynamic compensation. And in fact, it may be the only test that examines the VOR compensation. DVA can document the impairment, and that's very important to differentiate from pathology. In other words, patients with the same pathology can have low or high level of impairment based on the level of compensation. This makes the DVA test a good tool to assess the effectiveness of rehabilitation and exercise-based therapies. The early versions of DVA relied on testing that did not involve any instrumentation. In the non-instrumented or bedside DVA, the patient is seated at a given distance from an eye chart. The examiner asks the patient to read the lowest line without moving the head. This provides the baseline visual acuity. This is sometimes called the static visual acuity, which is fine, but can confuse the patient because they expect this value to match what they get in the standard eye exam from their optometrist or ophthalmologist. It often does not, and that's why baseline visual acuity is probably a more appropriate terminology here. The next step is to ask the patient to read the lowest recognizable line during head movements. This determines the dynamic visual acuity. In normal individuals, visual acuity decreases by fewer than 2 lines during head movements. After an acute vestibular loss, visual acuity deteriorates significantly during head movements, sometimes by as much as 6 lines. But the performance improves over time due to dynamic compensation. As you saw before, dynamic compensation tries to reduce retinal slip and to improve dynamic visual acuity. For the DVA test, head movements can be performed actively, meaning by the patient, or passively, meaning by the clinician. There's a difference of opinion if the two methods produce different results, and if so, which one is better. Passive testing seems to produce more repeatable results, and that's my preference. But others seem to prefer the active head movements. The prescribed head rotations in the bedside DVA are sinusoidal with the frequency of about 2 Hz or 2 cycles per second. That means the head moves from one side to the other side and back to the starting point in half a second. Usually a metronome is used to synchronize the head movements. The problem is that the input to the vestibular system is the head velocity and not the frequency. So the peak velocity can vary significantly depending on the amplitude of the head movements. For example, if I move my head at about plus minus 10 degrees, the peak velocity is about 125 degrees per second. If I move my head at plus minus 30 degrees, the peak velocity is closer to 375 degrees per second. And that's one of the issues with the bedside testing because we do not have full control of the head velocity. In the DVA testing, the head movements can be performed in the horizontal, also called the yaw plane, or in the vertical, which is also called the pitch plane. and finally in the roll plane. There are a few limitations associated with the bedside DVA test. One of the major limitations is that the letters are visible during the entire head movement. Because the head velocity varies throughout the head rotation, the patient can try to read the letters during the slow parts of the head movement. The other limitation is that the bedside test does not differentiate between the visual acuity for movements toward or away from the side of lesion. As you saw before, there's a difference in the dynamic visual acuity for the two sides in patients with the unilateral vestibular loss. In the computerized DVA test, the patient is seated at the prescribed distance from a computer screen. The patient wears an inertial measurement unit, or IMU, that can measure the head movements in 3 dimensions. The older IMU units were wired, but the new versions are wireless, which is preferable because it does not restrict head movements. In place of the eye chart, the computer displays images that the patient needs to identify. The images can be letter, words, or most commonly optotypes. Typical optotypes include tumbling E's or Landolt C's. The patient is asked to identify the direction of the optotypes, such as up, down, right, or left. The DVA testing system at Bertec is called Bertec Vision Advantage, or BVA. You can see here that the patient is wearing a wireless head motion sensor and she's sitting in front of a laptop. As she moves her head, concentric circles in the middle of the screen provide feedback about how fast the head is moving and what the acceptable range is. Once the optotype is displayed, the patient calls out the direction and the examiner enters the choice. As we discussed, the other option is for passive head motion, where the examiner moves the head. Before determining the dynamic visual acuity, the computerized system first determines 2 parameters. The first parameter, as we discussed, is the baseline visual acuity, which is the visual acuity with the head at rest. The second parameter is called by different names. Let's call it the visual processing time here. It refers to the minimum time that's required for the letter or the optotype to stay on the screen before visual perception fails and the patient is unable to see the image. Remember, one of the limitations of the bedside test was that the letters were displayed the whole time. The goal in the computerized system is to display the image long enough for the patient to see it, but short enough so that the head velocity remains relatively constant during the letter display. We can do that by knowing the visual processing time. Patients with excessively long visual processing time cannot be tested accurately, and the software will warn the examiner. These types of excessively long visual processing times are often associated with central processing abnormalities. For example, you can see that in patients with the concussion. For dynamic visual acuity, the computer system keeps track of the head velocity and displays the optotypes only when the velocity is within the prescribed range. As we talked about the bedside testing, the head movements can be performed actively or passively. The most common head velocity profile is sinusoidal within the range of 80 to 120 degrees per second for horizontal or yaw movements. During the test, the patient is asked to identify the direction or orientation of the optotype, very similar to what one goes through during an eye exam. The computer reduces or enlarges the size of the optotype based on if the patient correctly identifies the direction in the previous trial. A threshold search algorithm determines the limit of visual acuity based on the entire profile of correct and incorrect answers. This slide shows a typical presentation of the DVA results. On the right-hand side, you see a table that lists what size optotype was displayed and if the patient identified its direction correctly. There are two tables, one for head movements in one direction, in this case leftward DVA, and one for the opposite direction, in this case rightward DVA. The graph at the top shows the progression of the test from the beginning to the point where the computer is able to determine the threshold. It looks like the test took longer for the leftward DVA. This happens if the patient can see the optotype and recognize its direction, but somehow because of lack of attention might call out the wrong direction, or if the wrong direction button is pushed on the remote. That seems to be the case in this test, with the third trial being where the wrong answer was provided. Good threshold search algorithms can recover from such a mistake as long as there are not too many of them. On the left-hand side, at the top, you see the summary of the test results and the acuity levels for each direction. The results are also shown in the bar graph form below. The Bertec Vision Advantage system provides a consistency index that tells the user how reliable the estimated threshold is. This is an important parameter for having test-retest reliability and should be always reported along with the acuity levels. For example, the consistency index here is slightly lower for the leftward DVA. That's because of the mistake that was encountered in one of the trials. Below the graphs, you also see more summary, which shows the results both in the logmar form and also in the 2020 format. The report includes the average head velocity during the testing for each direction and how many lines of acuity were lost compared to the baseline. Here are the results from a patient who has a right vestibular lesion. The middle bar in the bar graph shows the baseline threshold, and the thin blue line represents 2 lines above the baseline threshold. As you can see, the patient's leftward DVA is considerably better than her right DVA. For the right DVA, the loss of acuity is approximately 3 lines. There's a companion test called the gaze stabilization test, or GST. GST is often performed with or in place of the DVA test. GST determines the head velocity that causes significant deterioration of visual acuity. The main difference is that in GST, the letter size is kept the same, and it is the head velocity that changes. The head velocity can range from as low as 30 degrees per second to as high as 300 degrees per second for high performer athletes. The benefit of GST is that it can compare an individual's performance with what would be the expected demands of daily activities. For example, patients whose GST results are lower than 80 to 85 degrees per second, these patients should be advised that they are at high risk of falling. Alternatively, GST can be used for individuals who are involved in higher demand activities, such as in sports or certain occupations. As I mentioned earlier, another benefit is that the therapist can prescribe head-eye coordination exercises starting at head velocities most appropriate for the patient. For example, in a patient with the GST of 120 degrees per second, you want to start the head-eye coordination exercises right around or slightly below that value and push that up as the patient progresses. Here are the results for a normal individual during the standard performance GST. In the standard performance test, the maximum velocity is limited to 150 degrees per second. Patients who can achieve that level of GST can perform their normal daily activities with no issues. So from a clinical point of view, there's no need to proceed beyond that level. My colleagues at the Banner Concussion Center, Shelley Massingill and Amy Alexander, prefer GST over DVA because if the patient's GST is higher than 100 degrees per second, By definition, he or she should have a normal DVA. So one can skip the DVA test and still have a very good idea about the head velocity where the patient needs to start the therapy session. The report for the GST is very similar to the DVA. The only exception is that in the graph and in the tables, instead of the optotype size, you see the head velocities. In fact, you see two different head velocities. The target velocity is the velocity that's set by the computer and is the desired velocity, and the other column you see is the achieved head velocity. This is the actual head velocity that the patient achieves during each trial. By relying on the achieved head velocity for the analysis, it's likely that the results will be more accurate. Here are the results for high-performance GST, where the head velocity can go up to 300 degrees per second. This test is appropriate for athletes and high-performing individuals. For example, this can be a very useful test for an athlete who might suffer a concussion. This athlete may perform at the normal level when compared to typical individuals, but if you compare his or her own performance to the performance before concussion, there might be a significant deterioration. So this kind of testing can provide a good quantitative method for determining when it's appropriate for the patient to resume play and go back to their activities. Here are the GST results for a patient with the right-sided lesion. As you can see, the GST velocity threshold is much lower at 75 degrees per second for rightward head movements compared to the GST of greater than 150 degrees per second for leftward head movements. This suggests that the patient will have an abnormal DVA for rightward head movements, which in this case he did. This also gives the therapist a good starting point at 75 degrees or slightly below to start head-eye coordination exercises. So to summarize, the computerized DVA test and GST provide objective tools for assessing the VOR function in different planes. Unlike the diagnostic tests of vestibular function, like the video head impulse testing or the caloric test, the DVA test can document the impairment and the level of compensation. The results of DVA and GST can be used to optimize the therapy protocol. For example, head-eye coordination exercises can be designed to gradually increase the GST threshold. The therapist can select the direction and head velocities that allow for targeted training. Thank you for your attention. First of all, let me say welcome everybody. I see so many familiar names, so it's nice to have you here. I'd just like to again just address this question about what happens with BPPV and DVA test. There have been a few studies. Most of these studies show that the patients with BPPV are basically immune to changes in the dynamic visual acuity, and that's to be expected because BPPV is a transient type of episodic vertigo. There's no structural damage to the uh, canals or its pathways, so it's just because the particles are moving around, you get a momentary abnormalities, and the DVA head velocities are usually not enough to trigger BPPV attack unless somebody's getting these wrong and you end up doing many trials. That's why we tend to limit the trials to 15 to 20 per each direction. If you can't get the DVA at that few tests, then you probably are not going to get the valid results at that time. You probably need to repeat it. So the answer, which I think the majority of the participants correctly answered, is that in most cases we will get for posterior canal BPPV, we get results normal to both sides. And more importantly, remember that the BPPV is a if you see an abnormality, you will expect it to see in the vertical VOR testing or vertical BVA testing. For horizontal tests, unlikely that you will see anything. So the likely answer is that you get normal to both directions.
Okay, fantastic. I'll stop sharing those results. And then Dr. Shearer, would you like to go into some of the questions that were submitted earlier, and then we'll launch another poll question when we have a lull in that conversation.
Okay, some of these questions were submitted early and some were just from a list of frequently asked questions that we have. And the first one being, what is really the purpose of the VOR reflex? Would you like to sum that up again for us, Dr. Barin?
Yeah, as we talked about here, the purpose of the VOR is to allow us to have clear vision during head movements. And that's a very important function that the VOR provides us. Most notably, you know that the patients who have no vestibular function, like patients who have been exposed to ototoxic medications, one of the biggest complaints they have is oscillopsia, which means when they're walking around, they tend to have all the images move up and down or side to side with their head movements. So the purpose of the VOR is to provide clear vision during head movements.
Thank you. The second one, we know that abnormalities in the visual or VOR pathway can cause loss of visual acuity during head movements, and that improves with the compensation process, both just from time and dynamic exercises. Do you have any time frame as to how long that takes, or is that another one of these that varies greatly with from patient to patient?
Well, it varies from patient to patient, but in most cases, I think that the milestones, static compensation for most individuals, younger age, occurs within the first 2 or 3 weeks after the onset of the lesion. The dynamic compensation can take longer depending on the level of activity for the patient and how much they're exposed to exercises and head movements. So for example, if you run into somebody in their 60s that they come to your clinic and you can't really find an identifying trigger for their dizziness, and then maybe you do a caloric test and you see that they don't have any function on the right side. So when you ask them, they say, oh yeah, when I was a child, I had a couple days of dizziness, but it went away, everything came back to normal. But in fact, what happened is that not everything came back to normal. Their loss may have been permanent, but their compensation at that young age was so good that they really didn't feel like any major changes in their behavior. That's not the same for an older person. Older person usually will have more trouble compensating. So the timetable is varied, but again, if you want to look at an average, about 6 to 8 weeks from the onset of the lesion, if they had their active people and not too old or not too young, which might be shorter.
Thank you. You mentioned during your talk that dynamic visual acuity is one of the few objective tests that can document not only visual acuity loss, but really the level of compensation with therapy. Can the bedside version be also used for that, or how much better is the computerized version for that?
Bedside testing is more or less like a bedside vestibular test. It gives you quick screening information, but it doesn't give you the detailed information that you need to make maybe deciding what head velocity to start the exercises. But I think it's a good, especially if you don't have a computerized system, then that's a really the only thing you have. I will go ahead and do that test. But again, this is something that I personally believe the computerized system adds a lot more to your assessment.
What, in just a few sentences, what's the major difference between the gaze stabilization test and DVA?
In the DVA, you hold the you had the head velocity constant, and you change the optotype until the image becomes blurry and not recognizable. In the GST test, you hold the optotype size constant, and you change the head velocity. So you basically, in both cases, you determine a threshold. In the case of DVA, you determine the threshold for the optotype size or the letter size. And in the case of GST, you determine the threshold for the head velocity.
And then finally, of those questions, both DVA and GST seem to be valuable tools in assessing therapies. From your talk or from the banner work, is it true that the GST tends to be more valuable in the elite athlete group or high performing patients and subjects than the DVA is? So the DVA seems to sort of reach a limit as to its usefulness.
Exactly, that is true, because the DVA is designed for not high performers. And I think my colleagues and Charlie, you may have been involved in that too. They did a study with one of the Major League Baseball team with the DVA and GST, and we had to actually, our BVA limit is 300 degrees per second for the GST, and we had to bump that up to 400 degrees because athletes at the major league level could actually achieve GST of 300 degrees. When you talk about the DVA at 100 degrees per second, for them, it's even if they're injured, that's probably something that they can do without much difficulty. So yes, GST is one that allows for high performance athletes and high performing for occupations that require high performance to be better characterized. Otherwise, in these cases, most of the DVA results will be normal. And if I could add one thing to that, is that and this may have not come up in the discussion before, I consider the DVA testing not so much of as a diagnostic test. In other words, I don't pay too much attention to, is it 2 lines of drop of visual acuity or is it 3 lines of drop, as much as I'd like to see what's happening over time. Yes, I think it's good measure to take the 2 lines of visual acuity drop as a benchmark. But if somebody has a 2.5 lines, it will not concern me as much if they have showing a sloping, downward sloping trend as they improve. So I think one of the questions that was raised is that do we consider 1 line of difference in DVA as abnormal result? No, I think 1 line of drop during DVA is, in most cases, it's just due to the head movements causing a little bit more difficulty seeing the object. 2 line of difference is just on the threshold. And as I said, I don't really too much pay attention to whether it's like 2.1, 1.9. I think those are kind of, again, you just want to look at the same person over time. That's the best use of DVA, in my opinion.
Right. And I might comment that, when we work with athletes, professional athletes in particular, it's so important to get baselines for them because they vary so widely. It is so hard to compare an athlete's performance to the general numbers out there, even in their sport. The best comparison is to themselves because their skill levels vary so widely. To that regard, I asked the question because I learned from these seminars a lot myself. Do you know of anyone that's using GST as a return to play metric? Are any of the
I think
major centers using that?
the Banner group uses that, I believe. but I don't know of any other group that's using that. Probably some of the participants know better than I do. If they're using it, they can just type it in the chat box. But I wanted to add one thing. I really think that as a quick assessment, um, most of the diagnostic centers, I'm talking about maybe audiologic practices and similar things, they don't often use DVA. And to me, if you have video head impulse testing and DVA, those two tests would be the first two tests I will do. And that will take total of 10 minutes. And you know a lot about the patient before you do anything else. I mean, that to me cuts down a lot on the interpretation and assessment, the overall assessment of the patient.
Another question was, does the VOR change after mild traumatic brain injury or concussion?
There's no definitive answer to that. I think sometimes the VOR changes, but some people think that it's not really the VOR that's that's affected by mild traumatic brain injuries. It's more the otolytic pathways or more the central pathways. So it depends on the nature of the traumatic event. One of the things that I have seen, which affects the canal function, this is in patients who have superior canal dehiscence. So for example, if you have a patient and gets a CT scan, many of us who have never had any symptoms of superior canal dehiscence, many of us will have what looks on the CT scans, thinning of the bone of the superior or anterior canal. But we never experience any symptoms. But some of these patients who get head injury, then the gray matter that was sitting on the open bony area and covering it and preventing any symptoms of that third window abnormalities, once they have a mild trauma, the gray matter moves, and now the open area becomes a problem for the patient, and the patient experiences canal dysfunction. In this case, it would be superior anterior canal dehiscence dysfunction, where the patient becomes sensitive to loud noises and those kinds of things. So again, it depends on the type of the traumatic brain injury, but I would like to hear your feedback on it too, Charlie, if you have your experience with that.
Well, you know, the old saying that when you've seen one concussion, you've seen one concussion. They all vary so much, but, you know, a lot of work at with the VOM test, the VOMS test, is related to those subjects. So we have a blog that we have started related to these webinars, and what I'd like to do is post a few articles related to that up on the blog after we're done, so that you know, over the next week or so, to kind of give you some references on that result. But yes, I feel that there is a change. What causes the change, you know, where the lesion is going to vary wildly from patient to patient. So then another question sort of in the same realm is, are you aware of any GST data on college football players? Do you know of any studies on norms for them?
I am not. Maybe you are, Charlie. I think I am not. I think the few studies that are done with the baselining, there have been something that's not exactly DVA, but something different, like a cobalt test or something like that. You may want to comment on that, Charlie.
Yeah, you know, as I saw that question, I cannot point to an article, but I do, I do know the person that should know, and that's our colleagues at Banner. So again, I will contact Shelley there and have a discussion with her and post on our blog any information that I find there, so you can all go there and find a much better answer than what I could give you.
As we wrap up here, guys, I'm just going to launch the poll again. We have one more question. So I'll put that up there and you can answer this. And then Dr. Barin, Dr. Shearer, you can address the answers once we get some going here. We have just a few more minutes. I saw another question come in.
Okay, the question is, what type of patients are more suitable for vestibular exercises? And as we see just the numbers coming up, I think that was an easy question maybe. So, okay, we'll wait a couple more seconds. Okay, so I'll go ahead and answer that. So obviously, the patients who have stable peripheral vestibular lesions, those are the most appropriate patients for vestibular rehab, vestibular exercises, because if you have lesions that are changing, then as soon as you start, rebuilding that database, then a new database becomes necessary. Having said that, that doesn't mean that the exercises are not completely, the exercises are completely out of question for fluctuating lesions like Meniere's disease or even patients with central abnormalities. For example, in terms of the central abnormalities, a number of studies have shown that patients with vestibular migraine can benefit from vestibular exercises as long as the therapist can take care not to worsen the symptoms. In patients with migraine, you can actually, the exercises can worsen the symptoms. So you just have to modify your rehab technique for migraine patients. And similarly for Meniere's patients who qualifies as a fluctuating peripheral lesion, exercises can be beneficial as long as these episodes of Meniere's are a few months apart. If the Meniere's attacks are occurring every 2 weeks, there's really not much of a chance for exercises to do anything. But if the Meniere's attacks are 3 months, 4 months, in between those, the exercises can help the patient recover faster. So the correct answer, the absolute correct answer, is the stable peripheral lesion, but the other ones, there's application for it.
The nice thing about these webinars and our participants and audience is there's so many experts out there that can share with us. And Peggy Roller posted on the chat the answer to the question about a study on gaze stabilization in high school football and college football players. So I'll refer you to the chat box for that reference. Thank you, Peggy.
Yep. Okay, we have another question from about which is more important, amplitude or velocity, and I think this is referring to the question of just the VOR in general, and I think I mentioned a little bit of that during my talk, that for the bedside testing we use frequency. But frequency is not actually the stimulus to the VOR. The stimulus to the VOR is the head velocity. It has nothing to do with the head amplitude at all. Now, the fact is that in the sinusoidal head motion, the 3 parameters of frequency, amplitude, and velocity, these 3 are related. If you specify 2 of them, the third one is going to be specified regardless of what you do. So basically, my preference for DVA and for X1, X2 exercises is that to limit the amplitude to a reasonable range, maybe plus minus 30 degrees, because the amplitude doesn't affect the function of the VOR. Now, it might be, again, Charlie might comment on that, it might affect some other oculomotor pathways, and that might be why we may need to do anything higher. But to me, the foremost, and I think to everybody, is the patient's safety is the most important thing. And especially in older individuals, if you're asking them to move their head at a very large amplitudes, you are putting them at risk for for neck or injury, which is number one reason in the audiologic ward, for number one reason for practitioners being sued for hurting the patient's neck during some of the diagnostic procedures. And I'm sure in the physical therapy ward and occupational therapy ward, it's something similar. But the more important thing is the amplitude is not really that important in terms of the VOR function, because everything that you see, if the VOR is functioning correctly, retinal slip is minimal, and so everything, the peak velocity occurs right about the center gaze. So you can make the amplitude larger and larger. It's not going to make much of a difference. So to me, I will generally stay with the not very big amplitude. Now, on the other hand, if you're looking at the gaze holding mechanisms like fixation and so forth, maybe you do need to go a little bit larger amplitude, but at that time you don't need to make it the bigger velocity. You can make it a very slow velocity, so to prevent any kind of neck injury. Again, there might be difference of opinion, and I think this I'm giving you this answer based on the physiology of the VOR. We might have a difference of opinion based on neurooptometry or based on physical therapy on that.
The only exception that I would make to that rule is the elite athlete. Again, when you have a hockey player or a player, an action sport like a point guard in a basketball team, their amplitudes have to be extremely large. So, the rules change for those based on not only the sport that they're playing, but also their position. So it's quite different for a pitcher than it is for a centerman on a hockey team. So,
yeah,
but
Charlie,
otherwise, yeah, I would agree.
If I could ask a follow-up question to that, when we're talking about the athletes and larger amplitude, is that for like an interaction between some sort of the oculomotor and the VOR function? Is that why you say that you need a bigger amplitude?
Well, it has to do with the peripheral versus central vision and the M cells and P cells and all of that as that goes on, because we switch systems. Anything that occurs outside of 30 degrees in the peripheral vision, we have to make an eye movement to get over there to see that. And so it gets more complicated. You're going from a detection system to a guidance system. And for the average person, their world's in this 30-degree realm, and that's considered normal, average. But boy, in the different sports, the rules get thrown out, and you add on top of that their movement. They're diving, they're skating backwards. All of those things just add more challenges to them.
There's one more question about the cutoff range for performance on GST or DVA on athletes. Again, this is something that's very much dependent on individuals. I think for normal daily activities, we have good numbers, as I said, like 100 degrees, or somebody who has a GST of 100 degrees, they will be able to do most of normal daily activities. If they have 150, that's even better. For individual athletes, I don't know of any cutoff. Maybe the study that Peggy posted may give some indications of that. Then again, I don't know if Charlie, you have any better answer on that.
I don't have any better answer, no.
But
I'll look for one.
This is an excellent conversation. I love the back and forth we have going on here. It sounds like a lot of good information for our blog as well. So we'll follow up and we can expand on any questions that were in the chat in the blog and maybe answer them thoroughly there, if that's okay with you guys, just to respect time. Thank you so much, Dr. Barin, Dr. Shearer, for your expertise in this area and for your time and your wonderful presentation. I'm just going to go ahead and plug some future webinars that we have coming up, as I love to do at the end. On June 30th, we have Dr. Nathan Morelli. He's from High Point University. He's going to be presenting on dual task deficits and neurodegenerative disease and the effects of task demands on dual task performance. And then on July 7th, we have Dr. Nassif Berme. He's the founder and president of Bertec, and he's going to be presenting on biomechanics from the lab to the clinic, a brief historical perspective. We recorded that one this morning, and it's really refreshing and interesting. So I hope you'll join us for both of those. Thank you so much for joining us and for your great questions. This audience had some wonderful questions. And please follow us at Bertec HQ on YouTube if you've missed any of this webinar. I think some people came in late, so you can catch what you missed there, and subscribe for future webinars. And of course, we're on all the other social media channels, LinkedIn, Facebook, Instagram, all of that at Bertec HQ. So thank you to both of you once again, and we hope you'll join us again for another webinar. Thank you.
Thank you, everyone.
Thanks, everybody.
Bye-bye.